Дорогие друзья, я вас всех приветствую на втором дне нашего мероприятия «Интервенциология». И мы открываем сессию, которая называется International Interventional. Dear Shyam, I really glad to see you. I really glad to see you. And thank you for your decision to be here in our endoscopy family. We can see you. You are on the screen. You are welcome to Sochi, to Russia.
Thank you, Boris. Thanks for the kind invitation. Pleasure.
Let's start.
Okay. So you asked me to talk about non-metallic interventions in endoscopic ultrasound, and I've chosen to discuss about the pancreas and the role of plastic stents and what we do with these plastic stents these days. I chose two particular indications. One is pancreatic duct drainage, and the second is selective use of plastic stents in patients with pancreatic fluid collections in the era of metal stents. So we will visit the first topic. We do pancreatic duct drainage for four particular reasons. One, when patients have painful obstructive pancreatitis, when there's an inability to access or cannulate the papilla during routine ERCP, patients with surgically altered anatomy in whom the papilla cannot be accessed by deep enteroscopy, and finally, patients with a disconnected pancreatic duct syndrome where an ERCP will not be helpful. So these are the two options for pancreatic duct drainage. One option is to do the rendezvous technique, where you puncture the pancreatic duct from the stomach and then advance it through the major duodenal papilla, or you just establish a communication between the pancreatic duct and the stomach, which we call pancreatic gastrostomy. I think when we perform these procedures, there are some technical considerations that are important. In all patients, we need to find the shortest distance between the pancreatic duct and the bowel lumen, whether it is the stomach or the small bowel. It should be as close as possible for an efficient procedure. It's important to avoid puncturing any intervening vasculature. And we should also find a position where the scope is very stable, otherwise we will result in technical failure. When puncturing, you target the most dilated portion of the main pancreatic duct because you need space for manipulating the guide wire. And usually, the transgastric approach is the preferred option. Specifically, when performing the rendezvous technique, duct dilation is not important. Therefore, you target the neck of the pancreas because it's directly in line with the major duodenal papilla, and it's easier to pass a guide wire. When you perform transluminal drainage, obviously, duct dilation is important. If you don't have good space in the pancreatic duct, then it becomes very, very difficult to create a communication between the stomach and the small bowel and the pancreatic duct. When preparing these patients, it's important to administer them intravenous antibiotics. A 19-gauge needle is critical. Usually we use the Flex 19 just because that needle is more manipulative than other needles. We prefer the use of a 0.025-inch guide wire that is in which the angle is curved. You need a 6 French cystotome as a cautery. You want to use biliary balloon dilators, preferably a 4-millimeter balloon that's either 2 or 4 centimeters in length. And then you use plastic stents, either 5 French or 7 French single pigtail stents, particularly for transgastric drainage. When the main pancreatic duct is dilated to more than 15 millimeters, then you've got a lot of space in which you can act. In these patients, a small caliber lumen-opposing metal stent, particularly 6 or 8 millimeters, may be useful. I'm now going to demonstrate a video of a patient in whom the rendezvous technique was performed. So this is a patient with obstructive pancreatitis, and you can see the pancreatic duct. The pancreas looks fairly normal. We are injecting the pancreatic duct with contrast. And you can see that we have punctured the neck region. Once that's done, we are now going to advance the guide wire. And the aim is to pass the guide wire through the obstructed pancreatic duct into the duodenal lumen. So once the guide wire is passed through the duodenal lumen, in the rendezvous technique, it's important to retract the needle, remove the echo endoscope, and then you pass your ERCP scope to identify the major duodenal papilla. Once the major duodenal papilla is identified, then there are two options. You can cannulate by the side of the guide wire, or you can grab the guide wire with a biopsy forceps, advance it through your sphincterotomy, and then perform your treatment. So now we can see that the papillotomy is passed over the guide wire, and the sphincterotomy, a minor papilla sphincterotomy. This patient has debism. So a minor papilla sphincterotomy is performed, and then after performing a sphincterotomy, you place a temporary plastic stent as a definitive treatment measure. So this is a fairly easy and a fairly straightforward technique called the rendezvous technique. And that's pretty much it. The second technique, which is called the pancreatic.
A patient with chronic calcific.
In a patient with pancreatic gastrostomy, this option is not possible because you can't reach the major duodenal papilla at all. So here, you find the pancreatic duct that is most dilated and that is most adjacent to the EUS transducer. Once more, the pancreatic duct is punctured with a 19-gauge needle. And after the duct is punctured, a pancreatogram is obtained. There is a pancreatogram. Then afterwards, you pass a guide wire. In this particular case, obviously, the guide wire cannot be passed through the major duodenal papilla because this patient has altered anatomy or the duct is completely disconnected. Now, here, over the guide wire, you pass a cystotome, which we are doing now. And after passing a cystotome through which a communication is established between the pancreatic duct and the stomach, a 4 millimeter balloon dilator is used to dilate the tract in between the stomach and the pancreatic duct. It's important, once again, to stay as close as possible to the stomach. And it is also important that the procedure is completely performed under EUS and fluoroscopic guidance and not endoscopic guidance. If you want to achieve endoscopic view, then this procedure will become a failure. Very often you move away from the pancreatic duct, you lose access, and performing a procedure becomes difficult. So this is a semi-blind procedure where it's performed only with EUS. And then over the guide wire, we are now advancing a plastic stent into the main pancreatic duct, and you leave the stent permanently in the stomach. The stent is never removed. So it's again a single 5 French or a 7 French 4 to 5 centimeter single pigtail plastic stent. And there you can see the stent being deployed and the scope being retracted. There are about 16 studies that have evaluated the technical outcomes in these patients, looking at close to 500 patients. And the adverse events include a post-procedure pancreatitis rate of about 5%. When you want to look at clinical outcomes in these patients, the pain resolves in a majority of patients, about 85%. Unfortunately, a quarter of the patients will have symptom recurrence over a period of 2 to 3 years. And because it's a small caliber stent, stent dysfunction can happen. If stent dysfunction happens, it's important to go by the side of the stent, pass a guide wire into the pancreatic duct, remove the existing plastic stent, and then replace it with another new stent. So in summary, EUS-guided intervention in the pancreatic duct is actually the most technically challenging EUS procedure, but it can be done in a small subset of carefully selected patients who will benefit from this intervention. Having said that, I will now switch gears and move to pancreatic fluid collections. And there is a role for pancreatic fluid collections, although we use lumen-opposing metal stents a lot. Generally, a plastic stent is required in patients who have an obstructive pancreatic duct. So in this particular case, you got a pancreatic fluid collection, and you got a calcification. So this is chronic pancreatitis with pseudocyst. In these patients, if a lumen-opposing stent is placed and removed, the rate of recurrence can be as high as 40%. So we recommend the placement of plastic stents instead of metal stents in these patients. The second group of patients who will benefit will be patients with an obstructive pancreatic duct and pancreatic necrosis who have a disconnected pancreatic duct, which means the main pancreatic duct is disconnected. You've got an isolated segment towards the body and the tail in whom there are recurrent collections. In these patients, once again, after you treat them with a lumen-opposing metal stent, it's important to replace them with a plastic stent. Otherwise, these fluid collections will tend to recur over a period of 3 to 4 years. Or if the collection is very large, you can use a metal stent in one place, a pancreatic stent in a plastic stent in another place, and then eventually you can remove the metal stent, leaving the plastic stent in place. The most important message here is in patients with pancreatic necrosis and disconnected pancreatic duct syndrome, it's important to leave plastic stents as a permanent method for draining the transected gland. So this is a patient with a disconnected main pancreatic duct where the duct in the tail is not communicating with the major duodenal papilla, and there's a recurrence of fluid collection. So generally, in these patients, what we tend to do is to first drain them with a lumen-opposing stent. The patient will come back to us in 4 to 6 weeks, and then we use a rat tooth forceps to remove the existing lumen-opposing metal stent. Once the stent is removed, it's important to identify the cavity through which the stent had drained. So in this particular case, you can see here is the pancreas, here is the pancreatic duct, and here is the cavity that was drained using a metal stent. Now the metal stent is gone. There's no fluid collections in the pancreas. Now, after we do that, there is the opening through which the metal stent was removed. Using an ERCP cannula, we advance a 0 to 5 inch guide wire into the cavity, and we perform 2 or 3 loops. And after we do that, we advance 1 to 2 7 French 4 centimeter double pigtail plastic stent into the necrotic cavity. And these stents are left in situ indefinitely. So you can see that the stent is being deployed. And I'm now injecting the main pancreatic duct just to show people why it is. And you can see the contrast flowing by the side of the plastic stent. So this is the reason to leave behind plastic stents, because there is a cavity through which the remnant pancreatic duct can be drained. The second, if you don't do this, then the patient will develop an internal fistula. So here is the stomach, here is a small residual pancreas, and there's a fistula in between the pancreas and the stomach. But unfortunately, the fistula is not communicating, and the patient in this particular case presented to us with severe symptoms. So once this happens and the patient has got severe pain, then here is the fistulous tract in the stomach, and here is the pancreas, and here is the pancreatic duct, and you can see it's getting obstructed. So what we are trying to do is to find the cavity in the gastric wall through which the remnant pancreas is attempting to drain. You make that cavity bigger by injecting normal saline. And once the cavity is more than 3 centimeters, you pass a 0 to 5 inch guide wire into the cavity from the stomach, and then you establish a larger fistula, once again, by using a cystotome, and then advancing your guide wire, and then placing your double pigtail plastic stent so that the pancreatic duct can drain into the stomach. So this is a patient, once again, if you don't do that, then this is what we do. This is the video that I showed earlier before, where you perform a pancreatic gastroscopy. So you have to replace with plastic stents in disconnected duct. If you don't do that, then this is the problem. They will develop an internal fistula, or they will have severe abdominal pain with a disconnected duct, requiring either a pancreatic gastrostomy or the creation of a fistulous tract into the stomach. The third situation in which the pancreatic duct drainage should be performed with a plastic stent is in patients with obstructive pancreatitis. So in this particular case, the pancreas looks completely normal. Here is the pancreatic duct, and we are trying to drain the pancreas. We are trying to establish a fluid collection. So we go to the unsent process, and slowly when you find the main pancreatic duct and you retract the scope slowly, you find a calcification occluding the main pancreatic duct. Now, as you retract the scope very slowly back into the stomach, you will visualize a pancreatic fluid collection, which is located right here. Once the pancreatic fluid collection has been identified, you have to drain it. In this particular case, I'm doing an ERCP to just confirm, to show you that this is an obstructive duct. So there you can see the contrast going to the major papilla. Nothing goes into the pancreas because the stone is large and it is blocking off the main pancreatic duct. So when this happens, then what we do is we don't place a lumen-opposing stent. We place plastic stents for draining or performing the cystgastroscopy and leave the stents in place permanently. So for pancreatic fluid collection, once again, in patients with a disconnected duct and in patients with an obstructive main pancreatic duct due to calcifications, plastic stents are indicated, and lumen-opposing metal stents may not be sufficient for management of these patients. So with this, I conclude my talk. Thank you.
Shyam, thank you so much for your lecture. And can you share your knowledge and your tips and tricks how to avoid vessels if it appears on the way of your needle?
Well, it becomes very difficult. If you got a vessel on the path, there's not a lot you can do, to be very honest with you. All that you should do is identify an alternate site for the drainage. Apart from that, there's not a lot you can do. So you use your Doppler, and then you find a track that is close to the existing track where you see the vessel. And the important thing is to make sure that you're not more than 10 millimeter away from the gastric lumen or the small bowel lumen. So if you've got a big vessel in the stomach, then you can go through the pylorus and see if you can place a short stent into the existing gland. But once again, that can help you in obstructive pancreatic duct, but not in patients with a disconnected duct, where the disconnection happens in the body of the pancreas. Then you can't go into the duodenum. You just have to be in the stomach and find another site through which you can do your work.
Okay, thank you. And one more question. It's not a gentle movement of the needle. If you do it this way, is it a risk of pancreatitis?
Pancreatitis is always a problem when you puncture pancreatic duct. But the advantage is that we are not performing this procedure generally in patients with an intact papilla. These are patients who have got chronic pancreatitis, who have got a disconnected duct, and therefore the risk of pancreatitis is usually low in these patients. They just have abdominal pain. No matter what we do in our practice is to give every patient rectal indomethacin. So if you puncture the pancreatic duct, we always give them rectal indomethacin, though there is no data to support that rectal indomethacin is useful for EUS-guided pancreatic duct interventions. We know it's useful for ERCP when the pancreas is inadvertently cannulated or in patients with suspected sphincter of body dysfunction. So two things we do is we give indomethacin. It's important to hydrate the patients with a ringer lactate as much as possible. 3, you can use a thin caliber needle, but since you have to pass a guide wire, there's nothing you can do but to pass a 19 gauge needle. You have to be worried about pancreatitis mostly in patients such as the one I showed, like pancreas divisum, in which the pancreatic duct is intact and there are no features of chronic pancreatitis. These are the patients who develop complications. In other patients, generally, pancreatitis is not a risk.
Okay, thank you. Дорогие друзья, есть какие-то вопросы для Шаяма? Hey, Shyam, it's really a pleasure for me to see you, and I hope in the nearest future we see not on the screen but shoulder by shoulder together. Thank you so much for your very, very interesting presentation. Thank you for your time, and have a nice weekend.
Thank you so much. Thank you, and good luck for the conference. Bye-bye.
Okay, thank you.